All right, Chapter 9 is the next disease discussion. What I'm trying to do is I'm trying to split it up into different components to make it easier for you now to transition from the physiology component to the pathophysiology. And what we're talking about here is major glomerular diseases. So we're talking about the capillary inside Bowman's capsule. Okay, that's where the disease process is going to take place. And the other one that will end up in this discussion will be on vascular diseases that not only can affect the glomeruli, but they can affect the whole system and the whole body. Okay? So the glomerular diseases can be broken down, and we'll break them down into nephrotic or nephritic syndromes and show you the differences in the severity of these. Okay? And then we'll talk about more of the vascular diseases at the end of the discussion, but very, very briefly, because the vascular diseases have already been talked about to a certain extent in the cardiovascular component, so I'm not going to go into Takayasu's disease and all these other diseases. Just know that they will affect the kidney as well, depending on which one we're talking about. Now, the biggest culprit that we're talking about here is glomerular capillary disease. Okay? And this is a very nice three-dimensional picture showing you the glomerular capillary tuft. Okay? Remember we talked about this before in physiology about how this is a very strange capillary network in the sense that it doesn't have a vein going out. It's got an arteriole going in, and it's got an arteriole going out. Okay? So in this disease process that attacks the glomerular network in here, it's going to be very specific to which portion of this actual glomerulus we're going to talk about. So let's get into the next topic about it. Okay? When you look at this picture here, imagine that you have this here. This is the actual glomerular capillary. I want to hear this in the computation. And you take this and you cut it out. Okay, I'm going to cut that little portion out, and then I'm going to cut just one part of the wall down so I'm looking at it. But still, what you have to have in the back of your mind at all times, when you're talking about glomerular capillary disease, you have to sort of imagine this three-dimensional capillary tuft network. Because the pictures that I'm going to show you next are usually just two-dimensional. And most students sort of lose the concept of what we're actually talking about. What we're actually going to talk about is just what is the wall itself. Talk about the wall itself. Okay? And the wall itself is made up of three different things. Okay? It's made of the capillary endothelial wall, which is where the blood side of it is. So under here, the capillary lumen, that's where the blood's running through the plasma and the RBCs and everything else. That's the endothelial cell processes. Okay? And this capillary is unique, not unique, but it's more than common in the sense that it's very fenestrated. Means that the capillary is wide open and allows fluid to pass through it actually fairly easily. It allows filtration to take place very easily. And it's called fenestrating. And then the next layer underneath that is a basal laminal layer that's composed of three parts: arera interna, arera media, and arera externa. And when you look at these lines, you can see it. This is an electron microscopy. You can see this sort of like whitish area here. You know it's an actual true barrier because the endothelial wall is right up against it. Okay, so it's literally a boundary zone. That's the interna. The next one, which is a darker band, is the media, and then the outer band here is the externa. That becomes important in the sense of these little layers are made of proteoglycans. They're not made out of fat. They're made out of proteoglycans. So it's like a mesh network that is preventing stuff from going through. Okay? Then the last component is the endothelial cells, which are made up of what's called podocytes. The reason it's called podocytes is because they have little feet. Okay? And these little podocyte cells have these little feet that limit what can come through. It basically limits your negatively charged molecules. It does it by these slit pores. Okay, so it's pretty selective. So if you had to say which one's more selective, and the answer is going to be the podocytes are very selective about what transfers across. What's very unselective is the actual endothelial cell processes. They pretty much let everything through to get against the actual basal laminal layer. Now, this 3D picture that I showed you before is taking this picture and just slicing it on a one-dimensional plane to produce this. When I was training, this is the picture that everything came out of the textbooks. Nobody gave you a three-dimensional view. So when you looked at this, you go like, okay, these are capillaries. And you're going like, what is that supposed to be? Okay? Versus you see this picture, this kind of makes sense. You see the blood vessel coming in, you see it breaking up into different capillaries, and eventually comes back in. Okay? Versus this one two-dimensional thing is a little bit more difficult to figure out. What I want you to understand is that the blood flow is coming in through the afferents here, okay, and it's going directly into these areas that are white. Okay? These areas that are white are the capillaries. The reason it's white on the drawing is what are we doing when we stain things? We basically clean out all the blood. Okay? So the white you see here is basically clean of all blood. That's why you see over here, which is the blood vessel, it's also white. Okay? So these white circles is actually where the blood's running through. So the green that you see in the inside lining, that's your actual capillary endothelial wall, which is what this cell is right here. This actually has a nucleus just because it is a cell. Okay? It forms the actual cell membrane around this area. Then the next line, which is the black, is the basal laminal layer. And then you see the next kind of, which are the visceral epithelial cells, which are these, that contain the podocytes. So these are actually living organisms. These are living cells. And that's kind of sometimes not passed on to you. Most people think this is a, it's a structural thing. It isn't. It's actually a living colander. It actually does active work. The reason that's an important concept for you to understand is that if it's a living organism, that means these individual cells can be attacked differently by different disease processes. And that's what we see. When you see a disease that only attacks the capillary wall, which is a thing like a vasculitis or an inflammation of the capillary wall, then you can see some effects of spilling certain things into the urine. Not so bad because it's already pretty well fenestrated, so it's really not going to cause too much of a problem. But if you spill too much of a large molecule like antibodies, then they'll bind to the next layer right underneath, which is the basal lamina layer. And if those antibodies become activated, or you can get what's called activation of complement cascade, which are basically things that produce holes in things, you can start punching holes through the actual whole basal lamina layer. And that can have devastating effects. A thing that normally would act like a fine filter now has basically got holes in it that allow proteins to go through it. Okay, or if it's really large, you can actually let even red blood cells flow through it, which is very, very bad. Okay? And the description of that can be what we call nephrotic to nephritic syndrome. In nephrotic syndrome, with the O, you're putting little holes in. Okay? In a nephritic syndrome, which means that you have the whole inflammatory cascade, which is why it's the I, inflammation, then you're putting big holes in things. Okay? So nephritic is much worse than nephrotic. Okay? And you're going to see that as a consequence. This is a nice picture, again, taking this area here, this area here, and then blowing it up to this. Okay, so it's a nice representation. They gave you here in this picture the actual names of all the different cells, the podocytes, which is the visceral epithelial cells, you have the basal lamina, okay, and then you have the capillary endothelial cell, which is the inner portion of the lining where the blood vessel's at. And then they show you an example of what it looks like via EM, which is electron microscopy. Very nicely done here. Okay? They actually caught a capillary inside in this EM photograph. Pretty nice. Now, what can happen is, and I don't expect you to memorize this, please don't. Okay? When you see slides like this is not going to be on the test. It's just for a generalized understanding. Okay? You can imagine this is not a simple structure, and the renal pathology slides are so complicated that you don't have a renal pathologist that will actually look at this in one hospital. he just doesn't get exposure to enough. So most hospitals will have pathologists. Almost every hospital in the United States has pathologists. I'd say almost every single hospital has pathologists. There's different kinds of pathologists. There's guys that just work in labs, some guys who will just do histo stuff, which will work on slides, okay? But the guys that really work on renal slides work usually in one or two major centers in the United States. Bethesda, which is a naval hospital, is where the Army Pathology Center is at, okay? That's really where most stuff is now sent for renal pathology slides in the United States. So if everything ever happens to Bethesda and we get a nuke there, we're going to lose all our pathologists for renal physiology slides, okay? But that's where the brain trust is for this kind of stuff. So when we do biopsies, what it's done is this stuff is processed or even not processed and sent up to Bethesda. They'll process it. They'll do EMs. They'll do all this other work on it to figure out what the problem is with the person, and they'll send you back a report. And the report's awesome. It's amazing what it can tell you, okay? What they'll talk to you about is they'll tell you, well, it's focal, okay? What focal basically means that 50% of the glomeruli are attacked by it. If it's more diffuse, it tells you that the whole glomeruli is being attacked by the disease process. If it's segmental, it's parts, small parts of it. It's global, it means the entire glomerular tuft is attacked. If it's membranous, it means that it's thickening the glomerulocapillary wall. If it's proliferative, it's actually telling you that you're seeing an increased number of cells, which sometimes can happen in inflammation. Sometimes you'll see what's called membranoproliferative, because you see both the presence of membranous and proliferative changes in the glomerulus. You can get what's called crescent formation, which is accumulation of cells inside the Bowman's capsule. Glomerulosclerosis, which is scarification, which usually that means that you already had an inflammatory damage, and now you've gone to the next step, which is now scarification. And then you can also have the active infection, which is inflammation of the glomerulus, which is what's called glomerulonephritis. So those are the kind of things that will get reported back to you as to what's going on. And from that, they'll give you a differential diagnosis. This is what it could be. Okay? And then you've got to figure it out from that point. Okay? But at least they give you a place to work off of, so you can sort of narrow down the problems and sort of figure out what the next set of tests needs to be done for that patient. Okay? Now, if you get a person to develop what's called nephrotic syndrome, so nephrotic syndrome is the lower degree of problems. It's not a severe one. Will be where you get proteinuria. Sometimes you get a little bit of protein in, but it's not enough to cause cast formation. So you're getting protein spillage, but not a lot of it. Okay? So you don't get cast. You can get hypoalbuminemia over time, so the person will develop peripheral edema, and sometimes you'll also see lipiduria and hyperlipidemia in these patients. And then you'll see a plasma creatinine, which usually is normal or slightly elevated in these individuals. This is caused by a non-inflammatory injury of the glomerulocapillary wall. Okay? The mechanisms involved in this is that you can get injury to the glomerular epithelial cells, okay, which is called things like minimal change disease, primary focal glomerulosclerosis, or you can see with cytokines from mononuclear cells actually damage the epithelial cells. You can also form what's called immune complex formation, which leads to complement activation in the subepithelial space, and this leads to what's called membranous nephropathy. This is attacking just the rara interna, so it's rara externa. It's not punching holes all the way through. It's just punching holes on the outer layer of it. And you can also get depositional diseases that affect the glomerular-based membrane, such as amyloid or diabetic nephropathy. It also leads to the nephrotic syndrome. This is what you'll see, the glomerular-based membrane. You'll get some activation, but not enough to punch severe holes through the base membrane. You'll see some changes where this is the normal side here, and you'll see it begin to change in the sense that the epithelial lining will begin to become more diffuse. The podocytes will begin to diffuse. So it's a disease process occurring on the internal part, the external part of the actual base membrane. Now, when you see podocyte thickening like this, that means the cells themselves, which are these podocyte, these we call visceral epithelial cells, they're having a hard time cleaning this thing up, okay? Because you're getting so much deposition in here, okay? These visceral epithelial cells, what their job is basically is this: they push the conveyor belt around and they clean the base membrane layer constantly. So if you see them beginning to work too much, okay, they will begin to thicken and start forming these kind of heavy outer layer like this, which indicates to you that the system is being overloaded. Okay? Usually that's from depositional diseases or complement activation where you get damaging on the outside portion. You're starting to leak too much stuff through. So what the cells are trying to basically do is they're trying to cover up the holes that are happening. The holes are small enough that it's not major, but it's starting to make the system break down. And what you start worrying about next is this is a complement cascade. Okay, this is the usually nephrotic syndromes will cause a little bit of cascades, complement activation, and you'll start forming these kind of protein setups where you start punching holes through things. What complement cascade is for is to break holes through bacteria, and as well as viral encapsulated sheaths. But unfortunately, it starts depositing into the actual vascular epithelium of the kidney, and you start seeing problems there as well. But when you get bigger issues is when you get antibody formation. Antibody formation, if it's not cleaned off quickly enough, it begins to activate and then begins to form holes all the way through because it activates the neutrophils. And that's the nephritic syndromes. When nephritic syndromes, that means you invite the inflammatory cascade to come in, and it kills the actual basement membrane. It actually drives holes in it. You can run cars through it at that point. They're huge. So this is nephritic syndrome. So at that point, you start getting massive proteinuria. You get so much proteinuria that you will start getting to form cast. So nephritic syndrome is an indication of severe breakdown in the filtration process where you get way too much filtration taking place of stuff that you don't want to get through. Okay? You will see eventually an increase in creatinine, and you see a decrease in GFR. The person develops edema because they lose so much protein into their urine, and a lot of them will develop significant hypertension during this process. The primary mechanisms that you're seeing in the nephritic syndrome is the circulating antibodies are basically attacking the glomerular basement membrane. And so you have what's called an anti-glomerular basement membrane disease. Now, how could that happen? I mean, it's your own glomerular basement membrane, right? So why is it activating it? Here's how it works. Okay, let's say you have a bacteria in your bloodstream. Okay, if your antibodies are activated to it, it binds to that bacteria, and the white cells come around and then destroy it. In the process of destroying, they do what's called microfragmentation of the cell wall. Okay, so the cell wall now is not one piece; it's now millions of pieces. Okay, well, those millions of pieces are going somewhere, and where they're going is they're going to the kidney for the body to get rid of. It also goes to the lung. Sometimes you'll get lung problems as well, but when it gets to the kidney, if it gets through the epithelial wall, it then embeds into the glomerular basement membrane. And as a consequence, the antibodies that are in your bloodstream will then bind to that and now think it's an enemy. Okay? So not necessarily that it already knows that it's its own cell, but it's now something that's bound to it, so it begins to mistake it. And as a consequence, you start getting things that attack and start punching huge holes into the actual basement membrane. This will lead to what's called immune complex formation and complement activation, things like IgA nephropathy, or very commonly what's seen as post-streptococcal glomerulonephritis. Okay? So when you have a kid who has strep throat, and 3 days later now they're edematous, that's not because their infection's under control. It could be. You could have knocked it out with the antibiotic, and if you actually draw a blood test on them, they have culture negative blood for strep. But what's happening is the strep wall that you just attacked with the antibiotic now is attacking the kidney. So this person now is developing acute glomerulonephritis. Okay, so the infection has already gotten gone, but now you got renal failure from the consequences of the antibiotic treatment of the nephritis, of the actual strep. Does that make sense? Yep. The problem is if it's binding to the kidney wall, okay, to the kidney glomerular wall, it doesn't differentiate bacteria from good friend. So this membrane is going to start perforating through. So you're going to start seeing the urine is going to filter, it's going to have too much filtrate going through. And you can lose big stuff like proteins and red blood cells. And in some kids, you can actually see them developing hematuria. That's a really bad sign that the glomerulonephritis is completely out of control. Okay, so these people don't have an infection anymore. Now the body's actually killing them by overproducing too much antibodies or reacting too aggressively against something that's really no longer an issue. Okay? Now, the way you can take care of this problem is you can plasmapherese them. You can take that individual and plasmapherese some of the antibodies, bring them back down, and then the body has the ability to get rid of this extra cellular debris so you can flush out the kidneys. So sometimes that's done as well. The other thing you'll see is that circulating antibodies directed against the neutrophil cytoplasmic antigens are way too high. And that's why I said plasmapheresis can remove some of these things. And when you look at the structures of the glomerular microcirculation, what you're looking at is the endothelial layer right here is negatively charged, but there's still pretty big fenestrated capillaries. Then the actual basement membrane is broken down into the three portions, which we'll show you the picture next. It's really not a lipid bilayer, but it's a protoglycan layer and a glycoprotein layer. So it's more like a kitchen sponge in this actual arrangement. And the third layer, which is the innermost layer where the urine's at, is going to be the podocytes with which we call the visceral epithelial cells, also called podocytes. These are very tightly junctioned and only allow for small compounds to get through. If you punch a huge hole through this, then usually it will start damaging these guys too, and they'll start opening up and cause the spillage of these big things like in nephritic syndrome. Remember, we talked about this in the test as well. The larger molecules are restricted. The negatively charged molecules, which are anionic molecules, are more heavily restricted in comparison to neutral or cationic molecules. So when somebody says which one's filters the most, the answer is the cations are filtered the most, next is neutral, and the last one, least filtered, is the anionic molecules normally. When you look at glomerular diseases, you can basically mark it down as four different damaging components. You can damage the visceral epithelial cells. You can cause immune complex formation. You can form antibodies. Or you can do the last one, which is very terrible, which is crescent formation, which indicates that you have cell-mediated damage, and now the actual outer visceral epithelial cells are actually significantly injured. When you look at the actual visceral epithelial cells, remember, these are the podocytes, okay? These are the ones that have the tight junctions that are holding everything apart. This is the fenestrated capillary here, followed by the actual blue, which is light blue, which is here, is the basal lamina layer, followed by the podocytes, which are here. And if you get podocyte injury, that's pretty bad because now you get excessive filtration, and then the bigger problem also in your hands is you can't clean out the basement membrane anymore. So if you damage the podocytes permanently, there's nothing to clean out the basement level, and eventually the filtration will stop. Okay? The actual basement membrane itself becomes permanently damaged because it begins to get fully filled with molecules that normally will get removed by the podocytes. So that's another thing you don't want to happen. The immune complex formation, okay, depending on where it actually gets through. If you have the immune complex formation in the rare externa, which is all the way in here, the externa is right up against the podocytes. Okay? It results in injury in the epithelial cells, and it's complement-mediated reaction. So it causes nephrotic syndrome. The reason it's able to produce the nephrotic syndrome only is because it's only punching a hole part way through the membrane. Okay? The one that's much more bad is this one, which is the immune complex in the lamina rare interna, where it binds in here and then punches the hole all the way through. Okay? So that's found in the nephritic syndrome. Okay? You get complement activation, okay, in the internal part, and then basically it attacks neutrophils, monocytes, and macrophages, which then enhances the inflammatory response. And with those guys involved, then you can start punching big holes through the system. Okay? This is a nice picture trying to show you that to three different layers. Okay? The lamina rara interna is the first layer, and that's been activated and punches holes in the nephritic syndrome. Yes? It does. The body is able to repair that, and the cells that are responsible for repairing that for these guys, which is the podocytes. The podocytes are the ones that repair the basal lamina. We think that the podocytes secrete this layer. It's not clear yet, but most people believe that they secrete this layer, and that's why they're responsible for maintaining it as well. They clean it. Okay? Yes? It repairs it with functional tissue if it can. If the holes get too big and the podocytes begin to become damaged, then it starts releasing collagen, which then becomes too tight of a matrix and it starts losing the actual, it starts scarifying it, which is not what you want to produce. Okay? Just imagine that this sponge layer here is very carefully managed. Okay? And these guys are not responsible for it. They're just sort of there. When you look at these capillaries, they really don't look different than any other capillary in your body. And you look at it chemically as well in the sense of what represents that capillary. It apparently doesn't look different from any other capillary in your body. It still produces all the stuff that prevents you from blood clotting, so you don't get active clotting in here, which is what you don't want, which is what I'll talk about later, which is microangiopathic thrombocytosis, which is what happens. Okay? So those cells are not different than all the rest of the blood vessel cells that line your blood vessels. Okay? But what makes the glomerulus kind of special are the podocytes, these guys. These guys are a different kind of chemical factory. They produce different kinds of proteins and protoglycans and glycoproteins in comparison to the vascular epithelial cells. So they're most likely the ones really responsible for this. Okay? Does that make sense? All right, you can also have antibodies that are directed against the glomerular basement membrane antigens, which was basically antibodies bind to the base membrane, which is what's shown here. Okay? And they cause the activation of the immune reaction, and eventually they can cause destruction of the actual membrane. The way they actually do this, of course, is the antibodies don't cause destruction themselves. Antibodies are just signals. Okay, so you can actually flood a place with antibodies. As long as the white cells don't come around, it's not going to be a problem too much. But these guys basically are sending signals out saying, hey, come and get this because whatever it is bad. So white cells will attach to here. So this glomerulus in here will become filled with neutrophils, white cells. They're normally circulating in your bloodstream. And that begins to pull them away and causes the person to react. Okay? Now, where do you think antibodies are found in very high concentrations? Okay, let me give you an example of how, if I were to tell you that you had a reaction to a medication, let's say I gave you a medication IV, what's a very early symptom of you getting an anaphylactic-like reaction? How many people have seen an anaphylactic reaction? What's the first thing the patient does? They vomit. They start vomiting right away. They start having severe abdominal pain. They say their insides burn up. Okay? That's how you know that you have an anaphylactic reaction. Sometimes people will tell you, my internal workings feel like they're burning up inside me. Okay? The reason that is because anything that's in contact with the outside world, like GI lining, anything that bacterially translocates, you want to identify it and tag it right away. So antibodies are actually sitting in high amounts in your GI tract. So when you give somebody a reaction, a drug that binds those antibodies and starts giving you an anaphylactic kind of reaction, the first place it's going to bind to is in the GI system, or possibly in your uterus as well if you're a female. Okay, males don't really get that. They get some cystic feelings. They feel it it's in their bladder But most of the time, men feel it in their stomach lining. They'll start feeling it burning up inside. They feel the insides. And it's not in the chest, it's in the belly. And it's because the GI tract is full of this antibodies. So it's the first place you'll see. So a lot of times if you see somebody gets a reaction to a drug, you'll see them nausea, vomiting. And the next thing you'll start seeing is the airway stuff, which is the edema. The edema is occurring inside their GI tract too. Their body's already reacting. It's trying to close everything down to prevent any more translocation. Does that make more sense? Okay. So if you see somebody tell you in the operating room, I'm feeling nauseous, and then they start vomiting, they may be getting hypotensive too from the histamine release, but the reason it initiated was from the GI system activating the antibodies. Okay, sorry, the antibodies activating the histamine release from the reaction from the antibody binding. Now, the worst case scenario is to get what's called crescent formation. Crescent formation is indicative of that your glomerular membrane has been so damaged that now the neutrophils have extruded through and now are in the urine side. Okay, so you imagine now the neutrophils that normally would stay in the blood vessel now have had a big enough hole that they can actually extrude themselves through the wall and now form on the outside. That's really bad because that means they're starting to secrete very high amounts of neutrophilic enzymes that are destroying all the glomerular tuft. And if you wait too long, that tuft will be gone. It'll disappear. And you'll lose all renal function in that person. Okay, and that's why it's called the crescent formation. So, and if you look at it, it looks like a paste. It's just a biograde waste product of the neutrophil activation. It's all the glomerular capillary and all the podocytes and all those guys that were in there, they're happy. They're dead now. They're floating in debris. Okay? So that leads to rapid renal failure and leads to the inability to filter. So creatinine jumps right through the roof. You don't want to ever see that. Okay? Where you actually can see this is from medicines. Medicines can induce this very quickly. Okay? Then you can have the last part of this discussion, which is like only 2 more slides, and we'll be done for the day. So you guys will be not too worried. Okay, is vascular injury, and these are the systemic vasculitides and the thrombotic microangiopathies that the book sort of glazes over. Basically, what it is it's an inflammation of the vascular wall, which is what this is. A systemic vasculitides with anti-neutrophil cytoplasmic antibody formation is an inflammatory process of the arteries. If you take a normal artery, you'll see that the lumen stays nice and intact. But as it become attacked by something, okay, because something's attacking the glomerular membrane of the actual blood vessel itself, you'll get inflammation. And that inflammation decreases blood flow, but it also will begin to form scarification. So sometimes you'll lose blood flow completely to an organ system, or worse, over time, is that the damaged wall will actually start forming aneurysms. So you can get microaneurysm formations inside the glomerulus and get microaneurysm formation inside the blood vessels. Things that will lead to do this and attack the kidney can be either the large vessel or small vessel arteriides, such as polyarteritis nodosa, and the other one that's well known to cause kidney failure is called Wegener's granulomatosis. Those are the 2 major ones. These are the actual ones that tend to attack the kidney. Down here, it separates it out into large versus medium arteries. The ones that mostly attack the kidney are going to be the small arteries, because of course the capillaries are the smaller ones inside the kidney. So really polyarteritis nodosa, that's why it's fitting in here, and Wegener's. Those are the 2 major culprits. Okay? The one you're not going to see to developing renal failure is usually Takayasu's or giant cell arteritis. Those are attacking large blood vessels, so they're not usually attacking the blood vessels inside the glomerular capillary wall. And then the last thing is that the capillary itself can become injured. Okay? The endothelial surface can become injured. And remember I told you that it's a chemically different than the visceral epithelial cells? Well, their job is to basically prevent clot formation from occurring. So if you damage the capillary endothelial wall, it basically begins to believe that you're bleeding internally. Okay? So the clotting cascade will become activated, which basically activates your platelets, and it starts forming what's called antibody-mediated endothelial injury, which then induces this micro thrombosis to take place inside the capillary. So what you look at when you're doing your actual work on your studies, you'll see that on this thing, you actually will see that there's blood clots inside here. So the actual capillary itself will contain blood clots in pieces. Okay, some of them will have it, some of them will not. But what happens, as soon as you get a blood clot inside a capillary like this, what happens to flow? It stops, infiltration stops. So this person will develop renal failure very quickly, okay, unless you reverse it. Thank goodness this doesn't happen very often, okay, but it's one of those things that if you see somebody tell you that the person is developing microangiopathic problems like that, you got an issue. Okay, so that's what this picture is here for, showing you here. Okay. All right, any questions? Yes? Okay. In nephritic syndrome, what was happening is that the antibiotic that you give a patient, okay, the antibiotics are there's three kinds of antibiotics, okay. There's antibiotics that cause cell lysis, and there's other antibiotics that just causes a stopping of the metabolic function inside the cell, okay, so it can't produce more of itself, okay. And there's other ones that actually attack the actual DNA of the cell, okay. The one that you have to worry about the most are the ones that are actually the lytic ones, that break up the bacteria. Because if you give a lytic antibiotic, once it breaks the bacteria, that bacteria is dead. So you've effectively eliminated it. The problem with this disease process is that that shell of that bacterial wall now is going everywhere. So it's not that the antibiotic is inducing the disease, it's rather that it's because of the lytic process is now allowing the next step, which is glomerulonephritis. Now, will you still have glomerulonephritis even if you don't get antibiotics? And the answer is yes, because the body produces antibodies to attack the strep. Okay, so once the body normally already is activated and starts attacking it, you'll start getting cell lysis, and still it can happen even without antibiotics. It's just that the antibiotics will make it occur very rapidly, too much, so, and within 3 days you'll see it. If somebody who is getting, say, a strep throat and then their antibodies are kicking in, then you may see it up to 5 to 7 days later that you'll get renal failure from acute post-streptococcal glomerulonephritis. Okay? Right. Any other questions?